we have a very exciting program for you, and I am going to start by sharing our screen so that you know what we are doing today. And I just want to give you quick reminders that it's very important that we avoid background noise, so please keep your microphone on mute. And this is a place we're going to collaborate and we are going to support each other. So that's why we encourage you to listen deeply. You never know when those ideas are going to be sparked and we come up with new initiatives, new projects, and new resources. If you have any problems with technology, please let us know. We have our colleagues, Kiana and Shelby, here to help us. And this is my favorite place to build relationships and to grow our community, to grow capacity in our community, because everything we do with purpose. Next, I want to start warming up your fingers. So to do that, we're going to start with today's chat storm. And the question for today is, what is the number one issue you would like to solve that you have in your group? We always have things come up, new ideas or problems or initiatives, and we don't know how to do it. What is that one thing that you would like us to brainstorm or to help you solve? I gave you some kind of hints here. Have you considered planning a social event for your group and you don't know how to do it? We can help with that. Or how about with the seasons changes, you are having low attendance in your group and you don't know how to get them out and coming to support groups. Or maybe you would like your support group to become a 501c3, but you don't know how to do that. There are resources for that too. Or something that I am dealing with right now in my group. How do you cope in your group when a member passes away? What do you do as a group? Or you as a support group leader, emotionally, how do you cope with those feelings? So if you have any ideas, any suggestions, I would love to share those. So what do we have? Oh, I love this one. Thank you, Katie. Time change and driving in the dark. I hate driving in the dark, I have to admit. How do you deal with toxic group members? Yeah, the ones that want to give medical advice. What do we do? How do we handle those situations? Or the ones that take over the group and they want to talk for 30 minutes? Thank you. That is a wonderful idea. Getting more members to participate in facilitating. That is a great suggestion, Judy. We appreciate that. Jack, your biggest issue, freezing of the gate. Does that mean how to help the members when they are coming to meetings and they are freezing, or finding a speaker to talk about freezing of gate? So either way, that is a big topic to cover in support groups. Also, we have Lauren, keeping track of members, those who have stopped coming, those who come once and don't return. Yeah, how do we follow up with them? Did we get their contact information, email, phone number? And is it the accurate information? Because I get a lot of times that I email them and then the email bounces back because a letter was missing or was incorrect. That's why, how do we keep track of them? Thank you. Karen suggests raising attendance for Jam for Joy and recruiting more students for our cinema therapy program. How to do that? Yes. Becoming a 501c3 and getting more people to take a leadership role. Thank you, Greg. Yay! I read your mind with that suggestion. Wonderful. So I use Black communications. That is wonderful. Thank you, everyone, for those suggestions. So we'll take note of that because all these suggestions can also be a topic for one of our support group roundtables. So I appreciate all those ideas. Thank you for that. And we are going to continue with today's program. And the next topic is, of course, if my computer wants to collaborate, we're going to do a quick poll. Okay? And here it is. Question number 1. Do you run frequent surveys to check what your group needs? Okay? Do you do it every 3 months? Do you do it every 6 months? Or once a year? Or maybe you haven't done it. So do you do surveys in your group? And if you don't, do you need help creating a survey? Do you know how to do one? Do you want to do it on paper or, in forms, a digital form? Oh, wow. All right. Some of you need help. Some of you don't. Ooh, not running surveys. Okay. I would love to hear why. If you're not doing surveys. Okay. We have almost everyone responded. Thank you very much. We appreciate your participation. And we're going to move on to the next topic. There you go. Thank you, Kiana, for running that poll. And today's topic, yes, inclusive groups and supporting atypical Parkinsonisms. I don't know about you, but I do have members in my group who have been diagnosed with PSP, MSA, or CBD. How do we support them when the treatments are so different, right? So to talk about this topic, we have a very special guest with us today. I don't know how many of you are familiar with CurePSP. So we invited them to join us today, and we have Courtney Malburg, and she's the Associate Director of Education with CurePSP. And to cover the topic of today, I'm going to pass it away to Courtney to talk more about inclusive groups. Thank you, Courtney, for being here.
Yeah, thanks for having me, everyone. I do have some slides. My name is Courtney, and Clemmy said that you can have the slides afterwards, so please don't feel like you have to scribble notes down or copy links. You will have access to all of these afterwards, and at the end of the presentation is my email and CurePSP's info email and phone line. So just the caveat of don't stress, you'll have access to all this information, and if you have further questions, feel free to reach out to me or us at any point. We're happy to help. So I won't dive into everything. I want to give an overview of us and PSP, CBD, and MSA first. Stop me at any point if there's questions. I will try to monitor the chat, but if I go a few minutes without saying anything about it, please feel free to flag that there's something waiting for me. So to start, as Clemmy said, I am the Associate Director of Education at CurePSP. I've been with CurePSP for about 2 years, coming from a few years at the Parkinson's Foundation. So very familiar with Parkinson's disease, and now very familiar with the way that people receive a Parkinson's disease diagnosis that later evolves to an atypical diagnosis. So we'll talk quite a bit about that. Don't want to dive into it too soon. All right, so today, a brief overview of what I'll be chatting about is talking about the diseases themselves, PSP, CBD, and MSA, and how they differ from Parkinson's. So getting a little neurological here. And then we will dive into supporting people with these diagnoses in a Parkinson's-focused environment. And then lastly, I will make sure you are well aware of CurePSP's resources and programs. I just want to check the time quickly to make sure I'm aware. Okay, thank you. So CurePSP is an organization of about 20 people and growing. When I started, we were at 15, so it's a pretty good 2-year growth. We're expanding our care across the world. And the diseases I've mentioned are progressive supranuclear palsy, PSP, Corticobasal Degeneration / syndrome, CBD, CBS. There's a lot of different opinions on whether it's CBD or CBS, so we tend to refer to both of them, and then people can mention them as necessary. So if you hear one or the other, know that it's the same diagnosis. And then lastly, multiple system atrophy. And I do want to flag for this last diagnosis, MSA, we do partner very closely with Mission MSA, which is an organization that does focus on MSA. Our support groups are covered by the same umbrella. So anything you see with MSA typically covers both CurePSP and MSA. It is a little bit confusing, but you can't go wrong in any direction you go to, whether it's us or Mission MSA. So just want to flag them for you. So what CurePSP does is we kind of have these 3 pillars, we call it, of care, consciousness, and cure. Care is kind of where me and my team, the patient and care partner advocacy team, sit, where we get to work directly with people with the diagnoses and support groups, and also create educational programs and materials. Consciousness is kind of educating healthcare professionals on these diseases because they are so rare. And then lastly, cure, we have a really great research arm where we fund research. We connect people to research and clinical trials and make sure that, we do eventually, to our namesake, find a cure. So any questions before I dive into the diagnoses themselves? Oh, I do see a chat. Oh, thank you. It's the web page. Okay, so the first thing I want to know is how familiar people are with these diagnoses. So the PSP, CBD, and MSA. Feel free to chat, raise your hand physically, or unmute yourselves. I just am kind of curious. So you can rank yourself 1 to 5 if you want to put a little number up or type in the chat how often you encounter these diagnoses. 2. Okay, thank you. Appreciate that, Dave. 4.5. Okay. 1. Okay, we have a good spread for, okay, this is super helpful. Okay, so it sounds like I'll kind of break them down, and if you are familiar, then it'll be a refresher. There's no harm in a refresher, I hope. 3. Okay, great. Perfect. Thank you for giving me that intel. It's helpful to know. Going, kill. Oh, I heard someone unmute. They have something. Okay. Okay, carrying on then. Parkinsonism is an umbrella term, and this will differ a little bit per person you talk to, but this is kind of how we at CurePSP see Parkinsonism. So it's an umbrella term to describe bradykinesia, rigidity, postural instability, and tremor, 4 very common symptoms of Parkinson's that I'm sure you all see quite a bit in your groups, including atypicals. And so the way I like to think of it, if you're not familiar with these, is that Parkinson's disease and the atypicals fall under this umbrella of Parkinsonism. So they have the same kind of basic symptoms, but they differ quite a bit in their presentation and progression, which you'll see here. I like to think of finding the difference between PSP, CBD, and MSA versus Parkinson's to fall into these categories. There's really early falls due to postural instability. So maybe someone comes to your group newly diagnosed, they were diagnosed 6 months to a year ago, but they're falling quite a bit for something you wouldn't typically see in Parkinson's. Similarly, you see someone who was newly diagnosed a year ago, 2 years ago, and they're having some really intense symptoms that feel a little bit more advanced than you would see in others in your group. The third one is early dysphagia, and that's swallowing dysfunction. If you're seeing someone who, once again, is maybe 2 or 3 years into a diagnosis and really having difficulty with that swallowing and eating and maybe considering a feeding tube, that could be a flag that it might not be Parkinson's. And then lastly, and this is the most important, I think, for us to know, is that these diagnoses don't respond to carbidopa-levodopa in the same way that they do to Parkinson's. Some people might experience some benefit from it. Neurologists, of course, upon a Parkinson's suspicion or diagnosis, will put people on these medications. But a lot of people with these diagnoses just don't respond to them, and in fact might have some more intense negative side effects. So this last part I say is important because that really can be a morale killer. If somebody receives a Parkinson's diagnosis and hears, okay, my symptoms can be managed really well by this medication, I need to be, really careful about taking it on time, but there is a treatment. there is something that can help me manage my symptoms every day. For people with these diagnoses, if they're coming from a Parkinson's diagnosis originally that has been then corrected, it can be really disheartening to hear that there is not a treatment per se in the same way that they thought so with Parkinson's. So it's really important, I think, to be sensitive to that kind of loss and honestly grief of treatment. And so I think that's really important to be sensitive and aware of. And then down here, this is more healthcare professional facing, but if you ever find that interesting, I talk about this again. We have a quick guide, which there's no such thing as a quick guide when it talks about differential diagnosis, but relative to, typical diagnoses sitting in a neurologist's room, we have a guide that kind of shows these flags with a little bit more nuance of comparing Parkinson's to these diagnoses. I wanted to show just a quick kind of table of the differences. I could go on for hours and hours, and I'm sure you guys have all seen symptoms that vary from this box, but these are what we consider like the hallmark symptoms. The things that, when you quick Google or quick talk to neurologists, they say, oh, PSP has this, CBD has this, MSA has this. And I'm going to go through them quickly. Feel free to pause if you want to talk more about them. But the first one is with PSP. The biggest thing with PSP is eye symptoms, ocular symptoms. And this doesn't mean blindness. People with PSP don't lose their vision. It's actually all to do with the movement of the eye muscles. And so people with PSP will have difficulty looking side to side and up and down. And so that's one of the kind of first, aside from the four flags I mentioned, it's one of the first things that happens that might make a neurologist think, this could not be Parkinson's. So that can cause a lot of issues with safety. So, if you can't look down to see the curb in front of you, or, the mess your dog made, like you might trip on something. It can also make driving very dangerous, as you can't, check your peripherals. You can only see kind of straight in front, and can also affect, activities of daily living, like showering, but also things like reading, watching TV, if you're having a hard time tracking those moving objects or tracking along a page. Of course, occupational therapists can really help find adaptations, but just know that that's the very common symptom in PSP. A really unique part of PSP is that when people have falls, they fall backwards rather than forwards, which is very hallmark in Parkinson's. So of course, a one-off fall backwards doesn't really mean they have PSP, but if they're falling backwards when they fall because of their postural instability and their inability to maintain balance, that can be a big sign that maybe it's a PSP. Something else is the next two, rocket sign and impulsivity, go together. People with PSP tend to experience impulsivity, not just in their decisions or their sociality, but in their movements. So rocket sign is when someone is seated and they kind of disregard their balance issues and their movement coordination and just stand up super fast, kind of like they would before the symptoms started. And that can cause them to fall. Or have a balance issue because they're not taking into account that their body isn't quite working the same way it used to. And then lastly, you'll see apathy a lot in PSP, which can be really difficult because it looks so similar to depression. And depression can obviously be caused by chemical reasons or, getting a diagnosis that changes, the fundamentals of your life. But apathy is something that can come alongside of PSP due to the area of the brain that it's in. Secondly, we have the hallmark symptoms of CBD. First and foremost, CBD is always asymmetric in presentation, meaning it will start on one side of the body. And that's kind of familiar. People with Parkinson's usually have symptoms maybe start on one side of the body, but CBD is explicitly one side. And then throughout the disease progression, CBD, the one side, will always maintain more symptomatic problems, which is interesting. And it doesn't matter which side. It's not, you're not right-handed, so it's the right side. It's just kind of seemingly random. The next one is myoclonus, which is jerky movements. It can be mistaken for tremor sometimes. It can be in any muscle in the body. Some people have it in their eyes, some people have it in their hands, some people have it in their legs, neck, trunk, etc. So anywhere you would typically find. The third one is not everyone with CBD will have this, but it's called alien limb syndrome. So I'm wondering if you can see my arm. Yeah. So what that can look like is any of your limbs will kind of do their own thing. And so it kind of like somebody is at rest, their arm might move up despite the fact that they're not trying to. They might push it down, but it still will flow up. So it's kind of their muscles not responding to immediate requests from your brain. It doesn't really, not painful or anything like that, but can be frustrating to people. sometimes the answer for them is just accepting that that's just how the body's going to be, as long as it's not uncomfortable to them or others. The other one is visual spatial impairments. So this can look like, depth of field issues, not really understanding where you are in space of your environment and things like that. And then lastly, executive dysfunction. Dementia in these three isn't super common. Memory issues aren't common. The most cognitive and behavioral issues are the apathy, impulsivity, and executive dysfunction. So you'll see inability slowly to stop being able to plan your days and your weeks, know what you have to do to get things done and things like that. And then MSA, last one, is actually quite similar to Parkinson's relative to the other two because it is an nucleopathy, excuse me. I always struggle with that word. It's the same protein in the brain as Parkinson's. So MSA, you will see early autonomic dysfunction, similar to what you see in more advanced Parkinson's with like urination, blood pressure, sleep behavior disorder, things like that. You'll see it much earlier in the diagnosis. And then severe balance issues, thinking, Parkinson's instability, but a little bit earlier and a little bit more severe. So I threw a lot at you, a lot of terms. Does anyone have any questions on the, science and background and symptomology of these diagnoses? And I'll give it a minute to people to type in the chat or unmute. Oh, Gregory, I see you. Go ahead. You can unmute.
Why is it that you think so many people are diagnosed early as, oh, well, you have Parkinson's? And then I read recently in a report that maybe they think now 35 to 50% of the people who are told they have Parkinson's actually have one of these three atypical Parkinson's. They just don't know enough to look for it and the signs.
Absolutely. Great question. So trying to think where I want to start. I'm having so many thoughts at once. I think the reason that most people with these diagnoses start with Parkinson's is because of that Parkinsonism. Neurologists are trained to see, the bradykinesia, the tremor, the rigidity, and that rightfully so means, Parkinsonism. Parkinson's disease is the most common Parkinsonism. And before these diseases, progress, it can look very similar to Parkinson's. They have a lot of the same, falls and balance issues and maybe some tremor or that myoclonus that I mentioned. It's only really once it progresses past that typical Parkinson's disease that it could be flagged. In a lot of cases, I will see people with PSP be initially diagnosed correctly because of that ocular eye issue. But these two, MSA, CVD, and then some of these PSP symptoms are just, when they're at their beginning, are just so similar to Parkinson's. It's really, I hate to say helpful, but it is sometimes helpful for people to have these more rare symptoms of PSP and CVD, like the ocular or the asymmetric presentation, because it can help them get diagnosed more quickly. But great question.
Yeah, I think so many non-MDSs who aren't trained to look for these minor changes, they when anyone goes to the doctor, you want to know what's wrong.
Mm-hmm.
The doctor wants to tell you what's wrong. And so they go to the first thing they can find, and then they say, oh, well, that's Parkinson's. When in fact, my other question would be, because I just have a new support group member who has I believe he has PSP because he can't look down or up.
Okay. We will definitely get into the support group aspect of that. So I'm noting that, and I think we'll definitely get on that. And there'll be a discussion question too.
Thank you.
Yeah, thank you.
Can somebody with Parkinson's have supranuclear issues in addition to the Parkinson's, or are they exclusive?
Oh, that's a good question. I don't feel medically qualified to answer that. I will say we do have people come to CurePSP, and say that they have received a Parkinson's plus PSP diagnosis, which my opinion on that is that at the end of the day, for me, and I want to say for you all as well, it doesn't quite matter as long as they're getting the support they feel they need. The only time I think medically I would be concerned about that is making sure that they have tried levodopa, of course, with their neurologist, and make sure that if it is Parkinson's plus PSP, that they're at least getting maybe some benefit from that medication. There's a question in the chat that is relevant to this about an MRI. And I do think that there are no biomarkers for these diagnoses. And so if it looks like, through the typical Parkinson's, like the DAT scan and things, it looks like Parkinson's. And then there is an MRI that looks like some of the areas that PSP are affected are also affected, then it's very possible. I do want to point out that supranuclear gaze palsy is its own diagnosis, which is, to your point, the eye movement. People can have that without PSP. That can be for different causes. It can be traumatic brain injury. It can be just different areas in that area of the brain. PSP is that entire category. So there is a chance that it's Parkinson's plus just that gaze palsy. Again, I'm not an MD, so I can't speak to that. But at the end of the day, it's kind of symptom management based. But I hope that answers your question. Okay, Karen, I feel it. Yes, see your hand up.
Hello. Just double checking what I heard. So these other diagnoses typically don't respond to the levodopa treatment?
Correct. Neurologists will almost always, to my knowledge, have people try it just, in the hopes that it kind of provides some relief. And some people do see some temporary relief, but most people don't, unfortunately.
Okay, just double checking that. Thanks.
Yeah, of course. Okay. I'm going to continue, but again, just feel free to stop me anytime. So this next slide is a little overwhelming. You'll have it to study later. To the point of there not being a medical treatment quite yet, I'm going to say yet because I'm hopeful that with all the research going, there will be some. This is kind of how I see the symptomology and the treatment and care that people can get with PSP, CBD, or MSA. It really is a kind of a holistic, using all possible resources in order to kind of maintain their quality of life, or at least adapt to their changes. So this is very similar to what you see in Parkinson's. This just might need to be a little bit more often and a little bit more intensive in the beginning. So here you'll see I mentioned early and frequent swallowing evaluations. I like to recommend, this is just a recommendation based on experience, not a medical recommendation, that people who are diagnosed with one of these diagnoses go and get a swallowing eval, even if they're not having swallowing issues. That way, when they start to feel some differences, they can go back to their speech language pathologist and have that evaluated, and then they can have some benchmarks as they progress in their diagnosis. That can go along with their speech therapy, of course. PT and OT, 2 therapy points, are very important. Exercise does not have the same benefit in these diagnoses as in PD. I think that's really worth mentioning. Of course, it does help, and it's just important for morale and just physical health, and also just getting people out of the house or moving. But it doesn't have the same kind of symptom reduction as it does in PD. So I really want to highlight that. Of course, we encourage exercise as long as possible and as much as possible and as safely as possible, but it doesn't have that same effect. So a lot of PT is actually just preventing falls. Of course, they will, encourage, tone strengthening and functionality, but a lot of it is just helping people stay safe when they're living their daily lives. And then OTs are a lot of them just helping them keep safe in their daily activities and exercises and activities and hobbies they enjoy doing. You'll see here, going to the early point, we should have early and frequent wheelchair, walker, assistive aid evaluations, and that should be with an OT. There's a lot of really specific, to the point of the retropropulsion that I mentioned, the falling backwards. There's a lot of special nuances that should be considered when using walkers, because they can help people with Parkinson's lean on them. But if you're falling backwards, that's a lot of consideration when thinking about assistive aids. So always recommend encouraging people to check in with an OT on aids before they go buy something, especially because they can be expensive, and I don't want people purchasing something that doesn't end up working out for them. Again, you'll see that pretty similar, seeing a physician or a neurologist for pharmacological treatments. While levodopa might not be the answer, of course, there are symptom-based medications that people can use in the same way there is in Parkinson's. So definitely worth encouraging people to see their neurologist and speak to their neurologist about medical options that can help with their individual symptom management. With PSP, the biggest thing I recommend for folks is a referral to a neuro-ophthalmologist. An ophthalmologist is an eye doctor. Neuro-ophthalmologist is an eye doctor as it relates to the brain. So as I said, it's not necessarily due to blindness or anything like that. It's the connection between the brain and the eyes. A neuro-ophthalmologist is not available to everyone, of course, geographically and just in life. And so it's not necessary, but in one of those dream world scenarios, a referral to that would be ideal. And then, of course, as with Parkinson's, care partner training is very important. Care partner burnout is very, very common because it happens so quickly. The disease progresses so quickly that sometimes care partners are doing so much early on, and they do so much for many years, and they also might just not be able to keep up with the demands of caring. So we'll talk more about that later. But any questions on this kind of comprehensive care chart? Okay, and you'll have this later to refer to if you'd like to. So I'm going to jump in now to kind of the support group, psychosocial issues that you all face. So any last questions about the diagnoses? Not that you can't ask them going forward, but just before we transition. Okay, sounds good. This is I've created kind of a case scenario. You all, I want your input after I read through these to see if these are familiar to you, what you would add. This is somebody who is coming into a support group feeling anxious. They haven't discussed with their support group leader yet. They're noticing their symptoms are different. And so, they're thinking, why aren't my medications helping me? Like my co-person, Dylan, is seemingly taking his medication and then he's able to go on a run. I take my medication and I feel just, as bad as I did 2 hours ago. As, symptoms progress, they might feel like I don't belong in this group. I'm a downer. I've heard that before. Like, I feel like a Debbie Downer, like I'm just constantly not doing well. These people have so much hope, but I feel like I don't belong. And then, like I mentioned with care partners, they may feel like, wow, I'm doing a lot more for my loved one 2 years in than my, members who are also 2 years in. Like, I feel really tired, but I feel like I'm being kind of a baby. Like, I feel like I'm feeling really burnt out, but they're not. And so this is kind of the experience of them coming into a group without kind of bringing up these issues. And so I'm curious if anybody has heard anything similar to this.
Yeah, I hear that a lot.
Okay. And so then the more positive experience is once they are able to kind of maybe speak with you as a support group leader or speak with the group themselves, they feel so much better for them. I mean, I'm gonna generalize for the sake of this, but people tend to feel so much better. For example, they might feel that although not everything and all the advice in this group, like medication or certain assistive devices or things like that, are applicable to them, they still value the communication or the community and the relationships they've built in this group. It still feels like a safe space. They still feel supported, and it feels similar enough that it feels like it's an important space in their life. A lot of people experience a lot of relief. I know it can be devastating to receive a new diagnosis, one that you're not familiar with, and that is a little bit more difficult to manage typically, but it can be such a relief. And I'm sure you've all seen this, to know that, okay, this is why this is my experience. This is why this is happening. And sometimes that's enough for people to be like, all right, cool, I'm good to keep going. A lot of people will find it to be really rewarding to be able to educate people on these diagnoses since they're so rare. They find it to just be like kind of a giving back of sorts to the community, which I find really valuable. And then lastly, like I mentioned, even though supports look different and they might not be able to contribute the same kind of advice, being able to, kind of experience this difficult piece of life together is really important. Okay, and so then going into all of you, here are some suggestions of things you can say if this happens. And I also, we have a lot of good experience with atypicals in here. And so I want you guys to chime in as well with things that you have said or experiences that you've had. But for instance, you can always offer to send people over to us with their new diagnoses. Something that people have asked me on the phone, I with my colleagues answer what we call our hope line. The numbers at the end of this presentation is like, can I not participate in my Parkinson's group and CurePSP? Of course they can. There's no rules. They can have 4 different support groups a month, 2 of them CurePSP, 2 of them with you guys. Like there's no rules. People can do whatever they want and do whatever feels best. So there's always an option to not leave this group, but stay in this group, and in addition, get support from CurePSP or Mission MSA. And then, of course, you can offer, if they would like,
I'm dealing
you
with
can.
something.
What was that?
You're back.
Okay, we're good. Okay, I thought I heard someone ask a question. Yeah, so, and then offering to tell the group about the diagnoses, if they would like you to be the one to kind of actually say the diagnoses, or if you want to open space, basically what can you do to support them in this change, and basically just allowing them to decide what feels best to them. So I am curious if you are willing, for those who have kind of dealt with this in their support groups, if there are any nuances you'd like to add or your own experiences.
I know that I have referred people to clinical trials that I've seen.
Great. Okay. Perfect.
But I would like to be able to, I know some that they're so desperate, you know, they don't know what to do. And some of them have the financial means to go anywhere to do pretty much anything. Where would the place be to, I don't know where to send them. Like, who's the big shots doing the biggest, best research, cutting edge?
Yes. So I wish I had better answers. Honestly, when me or my colleagues get asked this question, which happens 2 to 3 times a day, if not more, we send them to clinicaltrials.gov. What I like to do is pull out links of the trials that, of course, I can't speak to eligibility. I don't have their medical history, but it is nice for me to have a Word doc, which I can share with Clemmy if she's okay with that, of all of the trials, and then kind of locations, because there's some that are worldwide, there's some that are just in Asia, which I don't send to people in the US per se, things like that, of open trials. I will say, and I can send this in the chat after I stop sharing my screen, there is a trial opening at UCSF, which is University of California in San Francisco, hopefully November. That's just a rumor, but hopefully November. And that would be multiple locations, US based, 50 locations, I think. And they'll start enrolling people with PSP. Of course, that doesn't cover CBD or MSA, which is unfortunate. But people with PSP, that'll be a good option, and one that has really promising. It's a phase 2. So they're kind of really hopeful in that regard. And it just is helpful for people to get back to research. So I will try to remember to send that link in the chat once I'm done sharing. Yeah, Lauren, sorry, I see you saying.
Yeah, I've heard people come back and say that they're too far along in the disease to qualify for the clinical trials. Are most of the clinical trials based on people that are early on? And by the time they get the diagnosis, it seems like they're often not early on, I think.
Yes, yeah. I think a good amount of them are, I want to say like 5-ish years into onset. I don't think any of them are post-diagnosis. I do think it's symptom onset, which to your point is tricky because they might have gotten a diagnosis 5 years into symptom onset. I can't speak to all of them. There are so many worldwide, but that is just like an unfortunate reality of people who are more progressed. I do wish I had better answers for that.
Thanks.
Yeah. Greg, I saw your hand, I think.
Just to be aware, in Florida, there is an organization called Rise Above Parkinson's that will donate. You sign up and tell them what you want to do specifically with $1,000 per year. So if you want to fly to Bangladesh to take part in a study, or
oh, cool, yeah,
you know,
I didn't know
a center like Parkinson's has what's called centers of excellence. There are 42 of them, I think, currently, that you can tell people, you can give them a sense of if they have the financial means to travel there or if they want to participate in studies that are there. But this organization called Rise Above Parkinson's
Okay.
will give
gonna quick type that to
people
myself.
$1,000, and it's riseaboveparkinsons.org
Great.
is their contact. Dawn. You might want to find out if there are other foundations like that that will help, because Rise Above Parkinson's is specifically for Florida residents.
Got it. Okay. That's a very cool organization, though. I didn't know it existed. I'll look into that.
Use my name, you'll get ahead on the list.
Good to know. Thanks. I think I saw someone else's hand that I missed a minute ago. If that's true, please feel free. Okay. Yeah, if there's something else that you've encountered or have a question about, happy to kind of chat through this or have the group provide advice. But yeah, as you all know all too well, sometimes simply just asking what support they want is more than enough. And I keep saying this, but my contact is at the end. If you ever encounter a support group leader or member, excuse me, who wants help or just has questions, feel free to pass them over to us. And we're happy to share them. Once again, there's no rules. They can be a part of as many as they like. Lauren, I see your hand up, sorry.
Are there specific support groups online for PSP and MSA for the different conditions?
Yes. I'm actually going to skip ahead quickly. I'll go back through all this stuff. Don't worry. Yes. So this is our calendar. It's just a screenshot from our website, which obviously this is the link. And we have multiple different disease and kind of demographic splits of support groups. I should have taken more specific, but you see we have care partner support groups, and those are even spread out amongst themselves. So, you know, care partners of people with advanced diagnoses, care partners of people with MSA, CVD, and PSP, women care partners, men care partners, and then we have each of the disease specific groups, and then we have a group for anybody with any diagnoses. In addition, we have, you know, bereavement groups, we have adult children groups, so we really have quite a split, and we have people who do join multiple of them a month.
Because I often feel like we can't meet the needs in our just general group.
Mm-hmm.
And I feel bad. I'm like, I want to be able to tell them where to go so they can find someone to talk to.
Yeah. So yes, absolutely. And then something I forgot to put on, I'm trying to decide if I want to talk about this now. I'll talk about that in a minute, actually. I'm going to get ahead of myself if I continue on to that, but great question. Okay. The last thing, I kind of just had an example. We already kind of covered this, so I jumped ahead. But, you know, adapting the group to somebody who doesn't have a PD diagnosis and now has a different diagnosis. Did you have anything you wanted to add? And kind of acknowledging, even if your experience is different, did you have something you wanted to add? Just making sure they feel like they're still allowed to participate, even if they are different and feel different. They're allowed, and their experience of having a neurodegenerative disease is still valid and relatable. And also, you know, the community cares. So just kind of emphasizing that. Any last thoughts on the support group experience? Oh, I noticed a chat. Oh, thank you for sending that. Okay. Yeah. So we're going to transition, as you saw a sneak peek of, into our resources and programs. But any last thoughts on support groups? And of course, you have breakout rooms to discuss all that. Okay. Sounds good. And so then I know I'm running late. Sorry, I apologize for that. Chatting too much. But I'm just going to go through these quick. Well, there's links, you'll get them. And in the breakout groups, if you have any questions, I'll pop in all of them and I can answer any resource questions. So the first is that we do have our, brochure catalog. We have a bunch more digital than I can fit on here. You can also order physical packets. So if somebody is diagnosed, they can go in and order a packet to their home of their diagnoses. And then in addition, we have healthcare professional information packets, which you can go and give to neurologists. They can order themselves. It's a packet of all of the information, all the diseases. So feel free to do that if you ever come across a neurologist that you feel like might benefit from that. Here's an example of our 3 disease-specific books. They're available physically, digitally, and on audiobook, and they're currently being translated into Spanish and French. We have some continuing education opportunities for healthcare professionals. They all have, these 3 right here, have continuing education credits, which is a great perk, and healthcare professionals need those. And so it's nice to be like, hey, here's a course you can take. This one's worth X amount of credits. You need those every year anyway, might as well have it be this. And then this guide down here is what I mentioned earlier briefly. It's kind of it's a PDF that people can download and have in EMRs and medical records and things like that. We have lots of virtual events. Annually, we have called our CARE conference. This is November 19th and 20th virtually. It will be recorded in our YouTube page. If you register, it gets directly emailed to you, and it's 4 hours for 2 days, filled with healthcare professionals and also people with the experience that are talking about, familial changes and dynamics and things like that, as well as palliative care and what that is and how it differs from hospice and things like that. So highly encourage people to attend that. Even if just for education purposes. We have bi-monthly, every other month, Ask the Expert series is what we call it, where we have an expert come in and talk on a topic. I didn't have December's, I apologize. So this is back in July. This does exist on our YouTube page. In December, we're going to talk about healthcare disparities in PSP, CBD, and MSA. So that will be up on our webpage soon, and people can register for that. We also have a Spanish Ask the Expert. I meant to mention that. We have it 3 times a year, all in Spanish for people who speak Spanish, of course. Something I really, really want to highlight is our Quality of Life Respite Grant. This is a grant where people can apply for 100 hours of in-home care. The way it works is that you would find your own agency in your own city. You can, interview people and find who you feel comfortable with, and then we cover 100 hours of that. You apply for that, and there's some eligibility criteria, but it's fantastic. You can apply as many times as you need until you get it. You cannot get it more than once, but if you don't get accepted, you can apply again in the future. So I think that's a fantastic resource, and I always am shouting that from the rooftops. I covered these support groups. I do want to mention that in addition to the support groups, we have regional groups, which we don't run, but we have a list on our website of regional groups that people do run. So if there's someone near you who is interested in maybe that regional group, they can go on our website, and there's a list of those. So they can always find someone near them. And even if it's not an in-person group, there are peer supporters or people who have agreed to be contacted with any questions or concerns. And that's also based in that regional support group file, which I'll send again when I'm stop sharing. Here are CurePSP centers of care. We have, I think, 38 now across the US and Canada, and will expand into Europe in the coming years. These are places similar to the centers of excellence that were mentioned for Parkinson's, of centers who deliver really quality care for PSP, CBD, MSA. And a lot of these are involved in some research. So that's always really nice for people to hear. Again, here's my contact info. This is my direct email. I do oversee this info email and answer the phone, but you might also get to talk to one of my excellent colleagues who are very qualified and excellent. So feel free to send people here or give them my direct email, whatever you prefer. And so that's my presentation. I'll take any questions, or we can discuss in breakouts, because I'll come and join all of you at some point.
Yeah, thank you for that, Courtney. I think for, more specific questions, we can share those in breakouts, some things to think about in our group and for our members. So we're going to go into breakouts, and this time it will be, a little shorter given the time. We will come back at 1:15 so that we can stay on track. And when we go to breakouts, we are going to talk about how we support members with atypical Parkinsonisms in our groups. Something that I had to consider personally when I had someone diagnosed first is having volunteers who can help me, because Courtney mentioned the risks for falls, and I don't want anyone falling under my watch. So, who can be that extra set of eyes to help people as they are moving around, or they need to get some water, or they need to go to the bathroom, that we can keep them safe. We all experience something different in our groups, and we can talk about that. So Kian is going to send us to our breakouts, and there's going to be about 4 people in each room, and we're going to take only, let's say, 25 minutes in our groups to discuss, and make sure you have a designated note taker so that we can do share backs when we come back to the main room to share some of the things that we learned, on some ideas that we can share with everyone else, okay? I'm sorry if we had to stop your conversations. I know how these breakout rooms go, where you're like, we wish we had 5 more minutes. So, well, we're going to take some time to share back, and we're going to hit recording again. I think we are. So, let's go with group number 1. Do you remember what room number you were in?
Nope.
No, you
that
don't.
here.
Okay, so Judy seems to be room number 1, and she's like, I'm ready to share. No, you're not. You were 3. Okay, so Kiana, remind us who were in group number 1.
In room 1, we had Greg, Randy, and Tanny.
All right, Greg, Randy. Ooh,
I'm ready. I was the note taker.
All righty, Greg. Tell us, please, what did you share in your group?
Well, we talked about a number of things about, I've tried to make we have a person in one of our groups that has PSP. So I've tried to make a continuum of what I call neurodegenerative diseases, for all the way from benign essential tremor, idiopathic Parkinson's, early onset, familial, genetic, to the atypical Parkinson's, which, by the way, Courtney was kind enough to give us some numbers in the US. There's probably about 30,000 people with PSP. There's about 13,000 with MSA, and there's only about 2,000 with the CBD or CBS or whatever the heck they call it. Anyways, yeah, and Courtney just popped a thing up and said those are underestimates, no question about it. There's no way there is only 1 million people in America with Parkinson's. I don't know. We just don't know how to count them.
Yeah.
Some of our discussions really talked about things I want to make sure other people have heard. Clinicaltrials.gov is a great place to go to find, clinical trials. Then we started talking about telemedicine, and there is an organization that is licensed in all 50 states called Synapticure.
Yeah.
Yep, we talked
And
about
it's
that too. They're awesome.
Yeah. Synapticure.com. You get an hour and a half session, and they have PTs and OTs and psychologists and all the things that you can do. Here in the Panhandle of Florida, I'm working with some researchers from FSU to make the brain bus. It's a bus that's outfitted to help people in rural areas, because from Mobile, Alabama to Tallahassee, Florida is about 4.5 hours driving. There are no MDSs in that area. And Courtney talked with us about how difficult it is for people to sense the difference between just regular, or what I'll call typical, Parkinson's and PSP or MSA. So we are trying to put together a bus what we can't find is an MDS that wants to get on the bus and zoom around and take care of people, because as we all know, those of us with Parkinson's, while it may be inconvenient for a normal person to drive 3 hours, it's almost deadly to have a person with Parkinson's drive 3 hours. Sooner or later, you're going to not have a person with Parkinson's because they killed themselves and somebody else. So because of what Courtney talked about, all the things that change with our eyes and our vision and stuff like that. So that's enough, I think. Anything else either of the other two ladies want to add?
Thank you, Greg. A harsh reality, but yes, it is. Those long drives to see a specialist is almost impossible. So thank you for sharing. If Randy or Tanny have anything to add, you can. Okay, shaking your head no. Good job, Greg, reporting back. Let's go to group number 2. Who were in group number 2? Who was the note taker for group number 2?
I'm the guilty party.
All right, Dave.
And I warned them that I don't take notes very well. But we had Shelby, who's a new PMD person, and Lauren and Jack. And we were talking about difficulty with diagnoses and helping people. And lo and behold, Jack has been treated for PD and it's not responsive and he doesn't have the symptoms. So she just said that Jack go to the Cleveland Clinic and see if we can see a different neurologist there, because he's not far from them. So it was like we were talking about how do we get a neurologist to pass on information with a diagnosis. Lauren has successfully done that, and she has about 15 MDSs doing that. And I've got lonely Dr. Diaz here who's doing that for us. And I'm trying to get the foundation to turn me loose and supply every neurologist with these books, because I think they would do better coming from the doctor than from me handing them out when somebody walks into a group and says, oh, I was just diagnosed. I only see 1 or maybe 10 people that get diagnosed. But it's, getting the cooperation with doctors and was a subject, and Jack's conversation is frustrating because I hear that all the time, at least where I live. This is what you got, go away. I'll see you when I see you. And if you don't respond to the medication, well, I'll give you more. And that's not working well for most anybody. So I was thinking of Greg, and I said, I need to find a neurologist named Gus so he can get on the bus, as Paul Simon used to say. And that's about all I got.
Mm-hmm. Yeah, thank you. And in that concept, Greg, it may not be only one, because it would be a lot of work for, one movement disorder specialist to do that, but a group. So even though I understand finding 1 is hard, finding 4 is going to be even harder. But we have to keep trying, right? And see what works. So thank you, Dave, for sharing. Anyone from Dave's group that wants to add something? Or we're good? All right, we'll go to group number 3. Judy is excitedly waiting and ready to go. Go ahead, Judy.
Well, we had, excuse me, we had Myra and Katie and Karen. And Karen was talking about that she's got several support groups, I guess, online, most of them. Any in person, Karen?
Yes, the Parkinson Network Mount Diablo.
Yeah, so she had kind of the most experience with dealing with people other than straight Parkinson's, you know, a little bit of each. I was telling the group about a person I met at my church that actually I saw that she had some issues, and I approached her about it and found out that she had been having these symptoms and she couldn't get into a neurologist. And so I somehow luckily managed to get her in contact with my group, my neurology group, and they're seeing her today. So, so by some miracle, she got it 10 days and had an appointment. So, and I'm convinced that she's got a Parkinsonism of some kind because her early symptoms are bizarre. And there's freezing and rocking and things like that. So I know it doesn't look anything like what I know as Parkinson's, early Parkinson's at least. So that's going to be kind of it'll be new to me to be having, you know, that close a connection, I guess, with somebody that's obviously got something else and I don't know what yet. I'm looking at CBD. It looks, some of the symptoms are, but I don't know. I'm not a doctor, obviously. But so that was kind of the biggest one. And then we were actually also talking about Synapticure just before we got so rudely interrupted. And I've mentioned that I've written that name down several times and I've never followed up on it. So I think I might do some research on that now that I'm facilitating, you know, my own group. So I have to be more responsible. What was that?
It's in the chat, so it's there, so you can get it.
Yes, right. Thank you, Karen. And so, yeah, we talked a little bit about that, but didn't really have a lot of personal experience with dealing with the Parkinsonisms, I guess.
Yeah. Well, thank you, Judy. Anyone from the group that wants to add something to what Judy shared? Go ahead, Karen.
It doesn't matter what we all have at the end of the day, just the fact that we get together in groups and we can compare notes and share. I mean, there's so many things like Parkinson's and Parkinsonism and everything else. And as far as the YACS groups and the Jam for Joys, everybody's welcome. You know, there's a lot of people that, you know, started out with one diagnosis and ended up with another. And then there's care partners and family members, just everybody, you know. Just the connections. You got to make those connections. You know, you put out in the beginning, you know, the psychosocial sides, basically, and the demoralization, you know, all these things. The more you stay in your own head, the worse off you're going to be. But you got to just, it's not easy, you know, when you're stuck and you're paranoid and you've got all these feelings, but start small. And that's what I tell people when I meet them, you know, that haven't been introduced to these groups, you know, start small with this group or that group, and then just keep building. And it all started with a PMD Alliance support group, people with Judy and Perry, and here I am. I'm plugged into everywhere, and I just thank you all for how you've helped me, all of you.
Oh, thank you for sharing that, Karen. We're so fortunate to have you as part of the family. So,
it's a family. That's another thing we talked about.
Right.
We've become a family, and yeah, I'm an unofficial Cochrane with the name on my belly.
That is wonderful.
Exercise. You don't know who you're going to get, me or Robert. It's one to two or both.
That's beautiful. Thank you. And thank you everyone for sharing all those resources. Please remember to save the chat because we as support group leaders, having the knowledge of those resources is what makes support group successful, to be able to help people to connect to those resources, especially like you said, when they cannot drive, when you know, sometimes they cannot even leave the house. So having access to Synapticure, having access to exercise programs that are available online, support groups online are all beneficial for our members. So thank you very much to all. The recording will be available. And if you have any suggestions, if you have any questions, please send us an email or a phone call. We are here to help you. And I want to give a big thanks to Courtney and CurePSP for being such wonderful partners in this endeavor of helping our community live better. So thank you, everyone. We will see you next month for our November Support Group Leader Roundtable. And a big hug to all of you. Thank you very much. Thank you, Courtney. Take care.
Thank you
Bye-bye.
all. Nice to meet you.
Nice seeing everybody.
Bye.